And nowadays, some surgeons try to do sphincter saving operation even if there is an internal sphincter involvement. And regarding the functional and oncological outcomes, I would like to ask Bill first, what's your opinion? And then, Phil, would you comment on, as a pathologist, if there is a tumor in the internal sphincter, should be doing intersphincteric resection and anastomosis?
Well, in a way, you have to start answering this question by saying, well, I'm a surgeon who has about a 10% abdominoperineal rate, but then that depends upon what patients I'm sent. There are some people in the world who almost never do an abdominoperineal excision. The French are very reluctant to do abdominoperineal excisions and will give radiation and go very, very low down with anastomosis, perhaps preserving only a centimetre of internal sphincter. And there's a small number, most of us have done a small number of cases where we've kept the external sphincter but removed the whole of the internal sphincter. But there is no doubt that that group particularly has very dubious function afterwards. The continence is a relative term, but most of those people will not enjoy anything approaching the sort of continence that we would hope for ourselves or for our patients. If you're leaving only a centimetre of internal sphincter and you have irradiated that area, the chances of really satisfactory function must be getting down to a fairly small percentage. So I think that you will find differences of opinion about how low you can go. The top of the internal sphincter just invaded by tumour, which is then treated, well, you might be able to get away with a reasonable function and a successful curative low anterior resection. But we will be, when we come to the second version of our university course, we will still be arguing about these very low tumours from country to country. Northern Europe different from Southern Europe, very reluctant to sacrifice a French anus they are, whereas up north they'll say, well, you can live very nicely by irrigating a permanent colostomy, and you're better off that way than having episodes of incontinence from an anus, if you like, that's been denuded of too much of the internal sphincter and also damaged by radiation. So I think we'll always be arguing about this, and it will vary, and we will be patient-driven. Some patients just cannot bear the thought of a colostomy. Others say, just cure me, I don't mind about a colostomy. And between that are most people. Somewhere, they will listen to their surgeon. But I do believe that anyone having an abdominoperineal excision out there should take a second opinion, because there are a lot of people still doing abdominoperineals for tumours at 10, 12 centimetres, which really simply shouldn't be done. In other words, there are a lot of unnecessary abdominoperineals done, and anyone who's told they have to have a permanent colostomy, I would recommend that they should ask a second opinion from a more experienced, another surgeon who has been recommended to them at least, and secondly, that the surgeon who was initially consulted should be grateful to share that decision with another. If I was anywhere around here and they told me I had to have a colostomy, I'd say, okay, fine, I'm very happy with you as my surgeon, but I'd actually like to have Ahan Kuzu's opinion as to whether that's a good decision or not. And if you found it was a cancer at 12 centimetres, you'd say, I don't think this is necessary. And there's a lot of that going on in the world, I assure you.
Well, regarding the pathological view, what do you think?
Okay, so the most important thing is to get cure of the cancer and making sure that you can avoid a local recurrence and therefore a poorer survival. The anatomy of the lower rectum is complex, and the internal sphincter is actually a very small structure. So it varies between people, but it's not going to be more than around about sort of 6 millimeters in thickness. And therefore, if you have tumour involvement of that internal sphincter, then I'd be very worried that you might be increasing your risks of having an involved circumferential margin by trying to do a mesorectal excision with the intersphincteric. So my first recommendation would be to always avoid an involved margin, and if you are going to do an intersphincteric, hopefully the tumour doesn't involve the internal sphincter, or if it does, it's extremely superficial involvement because you haven't got very many millimetres down there to play with. So always be careful in the context of trying to avoid that involved margin.